So now we have our next speaker, our chief instructor, Dr. Tulika CHAUHAN. She will be presenting on the borderline cornea, when to proceed.
क्या करना है इसमें कुछ? Yeah, so it is there. Okay, are we there? A good afternoon to everyone. I'm Dr. Tulika and I'm going to present the next talk of this IC, When a Ride Goes Wrong. So when there's a borderline cornea, when we should proceed? I will try to cover a few points from my clinical practice, and you might have different opinion. So we can discuss that what should be the better thing to be done for the patient. I will tell you that what I have done for the patient. So we have discussed this already, that corneal ectasia is a sight-threatening complication of keratorefractive surgery, which is characterized by progressive steepening and thinning of the cornea. Why it is a problem? Because of irregular stigmatism, loss of BCVA. It can present date to years after the procedure. And the prevalence is theoretically low, estimated to be 0.04 to 0.6%, as Dr. Janji already told in his last talk. So the question is, are we underestimating it or are we understating the problem? The clinical significance, the post-LASIK ectasia is clinically important from two aspects. First of all, the condition is preventable, and most LASIK patients are young adults in whom the burden of the condition is greater. So understanding a safe threshold, what is borderline cornea? How thin is too thin? And how thick the cornea be to maintain the structural integrity? And how deep can the surgeon go? So these are the questions which we are searching in our day-to-day practice. And there is no number in the literature which can give us answer. So why do some patients with abnormal topographies not develop ectasia following keratorefractive surgeries, while some patients with normal-looking eyes do? Are thin corneas an independent risk factor for post-LASIK ectasia? The answer is corneal thickness alone is not a measure of corneal inherent structural stability. Crosslink corneas are stronger, stiffer, and more compact, that is thin. Keratoconus can be seen even in the eyes with thick corneas. So the pachymetry is not the only answer for this. Red flags are shape and size. We deal with curvature, diameter of the cornea, the pachymetry, of course, comorbidities like autoimmune disorders, scarred cornea, for example, post-RK, post-viral keratitis. What determines successful refractive outcome? We all know, we all do this. We do maximum for the patient, right? We do patient selection, a careful history, detailed informed consent about risk and benefits, meticulous preoperative testing. So these are the extensive examination which we all do in our day-to-day practice when we are doing refractive surgeries. There are relevant factors in refractive surgery screening, and these are intrinsic biochemical properties, for example, tomography, and the age, which we cannot change. So these factors, along with amount of refractive error, are the basis of most of the ectasia scoring system also, because these are intrinsic factors, and we have to consider these factors. There are alterable biochemical properties, for example, percentage tissue alter, which was extensively covered, amount of tissue altered by the keratorefractive procedure, and the residual stromal bed, that's remaining load-bearing tissue post-refractive procedure. Age is very important, as we all, as they mentioned, like young age, they have higher risk of ectasia, higher risk of unstable refraction, higher risk of non-compliance. And the older patient, the presbyopia may not allow glasses independence, may have to consider monovision. Lenticular status may make keratorefractive surgery moot, and often have other ocular comorbidities. So we'll discuss about the residual stromal bed. So what is the magic number? So I'm sure most of us are doing refractive surgery here, but is there a magic number what we are following? I don't think so. That's the answer to it. Yeah, because residual stromal bed should not be more than, you should not leave it more than 50% of original corneal thickness, since the structural support for the cornea has shown to be reside in the anterior cornea. For example, if the pre-surgery pachymetry is 546, then post-ablation RSB should be more than 273. It is recommended. Nobody has all the evidence to prove this, but that is the maximum thing which literatures tell us. Each surgeon must develop his and own safety limit for the RSB, but this should not be less than 300 micron. Though literature says that RSB should be between 250 to 300 micron, a lot of people follow these days that your RSB should be more than 300. Percentage altered, how preoperative corneal thickness combined with excimer laser ablation translates into postoperative corneal biomechanics. The PTA matrix representing the percentage of anterior corneal tissue that is modified during refractive surgery. The PTA takes into account the integrated relationship between preoperative corneal thickness, ablation depth, flap thickness, and the final RSB. So this is a calculation we all know we are following in a day-to-day clinic, and it's an independent indicator of post-operative corneal ectasia according to the literature. PTA more than 40% is negative prognostic indicator, and yeah. So we'll discuss some clinical scenario where I was confused, and I was confused that which surgery to be done for the patient. So there's a 32-year-old woman present for LASIK consultation with hopes of being less dependent on her glasses. She does not wear contact lenses. The external examination reveals excellent exposure with corneal diameter of 10 millimeter, anterior segment evaluation normal, fundus normal. This is a refractive screening for the patient, and yeah, we can see she has a moderate myopic astigmatism. My challenges were a relatively steep curvature around 46 and 47, small corneal diameter around 10 millimeter, though the cornea was normal, thin pachymetry 504 to 507 micron, and the large pupil size. So the challenge was in shape, size, and the thickness. So all the three factors were challenging for me to take decision. So when I calculated, my RSB was 326 micron, 333 micron, which is more than 50% of corneal thickness. My PTA was 35.2% and 34.2%, which is less than 40%, of course. So the surgical option I was looking for keratorefractive surgery and the lens procedure. So microkeratome LASIK, what were my challenges in this case? So the flap diameter is dependent on corneal curvature, and the diameter, the flap must be large enough to accommodate the large treatment zone, yet not so large that it extends into the limbus. Slight flap decentration, there is significant risk of limbal invasion and hemorrhage. In femtosecond LASIK and SMILE, the flap diameter is independent of corneal curvature, and the diameter is a preset diameter. So the limitation is centration is a concern. Flap edges close to limbus, limbal bleeding can happen. Then the PRK is my another option, in which no flap related risk, a large zone with the added blend, and the excellent centration should not be difficult to achieve. Limitation, in higher number we can get regression, haze, and the last option was a phakic implant, which is the cost is a factor of course, and the intraocular complications. So patient opted for PRK, and there's a discussion about haze and regression, and we have good RSP for the patient 434 and 439. So the take-home message is recognize the special challenges posted by the patient with microcornea. Surface ablation remains an important keratorefractive option in selected cases. The femtosecond laser is safe than microkeratome in patients with small, steep cornea because it offers more control over the flap diameter. These are my things, but you can always add like what are your challenges and what you think the right option for the patient should be. The another clinical scenario which I want to discuss here is a 25-year-old woman wearing RGP for 11 years. She tolerates a contact lens for 14 to 16 hours daily. The lens power has not changed in last 2 years. She was asked to leave her contact lens out before the examination, but she didn't have any glasses to wear, so wore the contact lens up to the time of her examination. Microscopic examination reveals 1 to 2 millimeter superficial vascularization in both corneas, consistent with her long-term contact lens wear. Corneal diameters are 11 millimeter horizontally. The rest of her examination is normal. The eyelid fissures appear adequate for the microkeratome suction ring. This is her refractive screening. She has quite a good high myopia, and on topography we find there's a mild inferior steepening in both eyes correspond to keratometry and refraction. Posterior elevations normal maps. So my challenges were, will there be adequate stromal bed for laser ablation to correct this amount of myopia and astigmatism? With spherical equivalent of -10 and 9.5, a conventional laser procedure can be estimated to be 120 micron ablation and 114 according to the refractive error to provide the complete correction. RSB is 285, 293, which is more than 50% of the CCT. And the PTA is 44.6 and 43.3%, which is more than 40. The corneal topography shows inferior steepening along with somewhat high K readings and slightly thin central pachymetry. Calls for critical evaluation for subclinical keratoconus. Is it contact lens warpage or molding? It can be. So we ask patient for the contact lens free period. Topography shows nearly complete resolution of inferior steepening and no inferior thinning on pachymetry. Slit lamp examination was unchanged. So the manifest refraction, what you can see here is the thing after at least 6 weeks of contact lens free period for this patient. And then the concern was in keratorefractive procedures, if we choose keratorefractive procedures, then the borderline stromal thickness for laser vision correction, PTA more than 40%, future enhancement not possible without enough corneal stroma. The treatment plan was phakic lens implant for this patient. We did toric implantable Collamer lenses, and the vision is fine. Patient has no vision problem. She's in the follow-up. The take-home message, the differentiation of subclinical keratoconus from contact lens-induced corneal warpage is important for both accurate surgical correction and safety. Phakic IOL implantation is a good option to discuss with patients who have suggestion of FFKC on their preoperative topography. Phakic IOL procedures equivalent or superior vision for the patient with inadequate or borderline stromal thickness for the laser vision connection. The last scenario which I want to discuss with you is a 30-year-old Asian woman who was interested in refractive surgery. She had worn contact lens for 10 years and had been out for 3 weeks. The pulmonary fissure was small and the lids were somewhat tight. The corneal diameter was 11 and IOP was 12. The slit lamp examination was normal and fundus was normal. This is a refractive screening of the patient, and I'll show the topography in the next page. Okay. So my challenges in this patient were the topography. I think it's not very clear. I'll show it. Relatively thin pachymetry, then increased risk of night vision symptoms with high astigmatism. Pachymetry maps reveals the thinnest portion of the cornea to be displaced inferior-temporal in the right eye and slightly displaced inferior-temporal in the left eye. So if you see this, so there's a little displacement. So it's one factor which is giving me a red flag. So examination in favor. BCVA is more than 20 by 20, patient for 25 years, stable refraction for 2 years, normal curvature and elevation maps, normal bad score. RSB is 353, 343, which is more than 50% of CCT, and the PTA is 29.6 and 32.1%. So the pachymetry curves follow the mean and standard deviation curve, indicating that corneal pachymetry increases appropriately as one progresses from thinnest portion of the cornea to the periphery. So the conclusion is, pachymetry finding alone are not sufficient for the surgeon to reject the patient as a candidate for the refractive surgery. Surgical plan, patient opted for PRK, and we discussed the risk of haze and the need of steroid for post-op. So thin pachymetry, tight lid, small pulmonary fissure, small corneal diameter, PRK seem to be a better option than LASIK sometimes. If you have to do microkeratom LASIK, then PRK is better option in such cases. So post-op patient was 20 by 20 plus, and this is the refraction of the patient. So here the careful analysis of corneal topography, power elevation, and thickness is especially important in highly astigmatic patient to rule out signs of pre-existing ectasia. Highly astigmatic patients should be presented with realistic vision expectations and warned about possible night vision problems. Successful correction of high astigmatism has potential to improve near as well as distance vision even in the young patient. So clinician must never rely solely on one measurement or data point in determining the patient's suitability for corneal refractive surgery or ectasia risk. Nevertheless, with improved screening protocols, enhanced understanding of corneal biomechanics, and judicious application of patient selection criteria, we can strive to reduce the incidence of post-operative ectasia as much as possible. So crucial is to understand, recognize, and accept the risk factor critical toward achieving a significant reduction in occurrence of this adverse effect.